Righty-ho, and we've got another doctor amongst us, and it's Dr. Yoni Goldwasser, the Director of Venture Development at Axel Springer Porsche. Now, this is a really exciting and really timely presentation, as Yoni will be talking whether AI can replace our doctors and nurses. Also, bear in mind that at the end of his presentation, Yoni will be doing a Q&A session, so make sure that you tune in and use the chat to ask some questions.
Hi, everyone. It's very nice to be joining you virtually. This is the first time for me talking to an audience that I can't see in front of me, so bear with me. Thank you for joining. I think I was just introduced. My name is Dr. Yoni Goldwasser. I have a background in medical engineering, a PhD in medical engineering. I also did consulting in Boston Consulting Group. I've been doing VC for a while, and I'm working currently as Director of Venture Development at APX in Berlin. Another thing that I'm doing in APX is we started the Digital Health Initiative. The idea is to help bring more successful startups to commercial success in Berlin and in Germany in general. And today I'm going to talk to you about whether or not AI will replace doctors and nurses. I'll just switch here. So I'm sure that everybody probably has an opinion about this question. And what I'm going to try and argue today is that not only is the answer to this question yes, that AI will replace doctors and nurses at some point, but the technologies to do it are already here. They're just not mature enough for actually for us to adopt them. By the way, I can't see the questions as you're asking them, but if you ask them at the end, I'll leave a little bit of time at the end of my talk so that I can go through and select a few to answer. So doctors and nurses. Doctors and nurses are made of three parts, essentially. And the first one I call Dr. House. That's the algorithmic part. That's the part where essentially, there's an algorithm that needs to reach a diagnosis, and from that, a prognosis. The second part I call C3PO. This is actually the physical manipulation of things in space. And the third part is Nurse Nightingale. I'm not sure if everybody's familiar with that reference, but look it up. Nurse Nightingale is considered the mother of modern nursing, and she typically is considered kind of a prototype for what bedside manner should be like. Although, to be fair to history and to Nurse Nightingale, she was also a statistician, and actually a lot of the progress that she made was not related to bedside manner, but rather the use of observation in statistics and nursing. So, let me first try to convince you that we are already seeing what we're seeing in medicine is progress towards this Dr. House of algorithms. And what you're seeing in the video that's running, if it's large enough in your screen, this is a demonstration by a large startup called Babylon at AWS Summit in London. And essentially what's going on is you can't hear the audio, but essentially there's a conversation between a bot and a patient. And the patient is being asked to describe his symptoms. And as the symptoms progress, you can hear more and more about it narrows down more and more what is going on. And at the end, it returns a diagnosis with a certain level of confidence. It's interesting to note that, of course, like all these AI systems, they are sometimes a little bit limited by the bias of the data that we feed them. So these Babylon had a snafu a little while back where it turned out that when the same symptoms were fed by men and women. Men were told they were having heart attacks, and women were told that they were being hysterical. This is to say that the AI has still a way to go in this case, but the idea is that if we feed it less biased training data, it will be able to do a less biased job. What we are already seeing AI also doing very well is anywhere that you need anything that's built on pattern recognition, and specifically around visual pattern recognition, specifically around pathology and radiology. So there are quite a few startups and large companies that are developing modules that allow algorithms to spot abnormalities in CTs and in X-rays and in MRIs. And the same thing is now happening as our ability to scan pathological slides becomes better, that we're actually seeing more and more of this also in pathology. So the next point is C3PO. This is the physical manipulation of space, and the simplest part of it is actually the part of really just manipulating patients, so to pick them up, to move them around, that type of thing. And that's obviously on the simpler end of things. This is what people normally think about when they think about robotics in medicine. Some sort of Da Vinci machine or something along these lines. These kind of robots are going to take a very long time, I think, until we see them completely automated through AI, just because there are too many degrees of motion and degrees of freedom in the motion that the different arms can take, and also with the response of the human tissue. Where we are probably going to see it happening sooner are these types of interventions where there's a lower number of degrees of freedom. So, for example, when you think about catheterization, if you actually look at what the physician does, she will be usually in a suite that's dedicated to this, and she'll have two screens that show her 2D images that are based on fluoroscopy, and she will be standing next to the patient's arm or leg and trying to push a wire into a catheter, and essentially she can push forward and twist, and there's a little, normally a little thing at the end that can also bend. So the numbers of the degrees of freedom here are actually not very large when you think about it in terms of vectors, and that's the type of also. This is exactly the type of system that can be very easily trained, either completely modeled in silico, or trained extensively ex vivo before you ever try to do this on the first patient. The last piece, and is usually where when I have live audiences, I get the most resistance for, is the bedside manner part, the soft part of medicine. People argue that you cannot replace the soft side of a nurse or a physician who actually interact with a patient just replace that with a computer. And my argument that actually that is also not true. So we're already seeing a lot of advances in the field of digital empathy and synthetic empathy. This is, of course, a little bit tongue-in-cheek, but we actually do have, this is based on an algorithm that tries to guess from an image what are the emotions that are contribute to it. And of course, this is, once again, it's cultural, it's limited by the training data, but it actually is starting to do a very good job. And a lot of these things are not coming actually, of course, from medicine or to target healthcare applications, but are actually coming from retail and gaming. So we can imagine a future where we have, and what you're looking right now is a completely artificially generated avatar, but you can imagine something like this also being created using the same technologies that create deepfakes. So you can actually take several photos of an actual person and then get that person to artificially say whatever you want them to. So we can imagine this type of solution actually being used to create an avatar that you now interact with as your healthcare provider. You wake up in the morning and your kid is sick, and so instead of taking him to the doctor's office, you open an app, and this avatar comes up. Again, this is still not completely lifelike, but we're not very far from the day where it's going to be pretty indistinguishable from an actual person. And you'll be talking to this to this virtual nurse, and you probably won't even know that she is fake. Another place that this is going to draw from is, again, from areas that have to do in retail and gaming. This is a little video that shows the lonely Japanese businessman who has this little avatar as a companion. And while for me, it creeps me out a little bit, to be completely honest. But the basic idea behind it is actually quite valid. And we also see that this is happening with the care for the elderly. So I think most of us agree that otherwise healthy young individuals should try to interact with other people. But there are people who actually require this type of support and companionship. And so we can imagine that the same technologies that are used to create this type of product can also be then turned to create an avatar that knows how to interact with you in order to elicit specific responses from you. And the thing is that we can use, because these avatars are completely synthetic, we can really generate one that would be perfect for you and for your needs. So it can be it can analyze what you would respond best to in terms of age, gender, anything like that. Also in terms of attitude, maybe you would respond better to somebody who's a little bit more tough or dry versus somebody else who responds more to this lightheartedness or humor or really just being nicer. And at least the software, on the software side, we should be able to generate anything like this. So the software doesn't actually limit us. What, again, does limit us is more things like ethical considerations. For example, if somebody is only comfortable with an avatar of a specific race, gender, age, do we program the system to always cater to that need, to that bias of the person? And it becomes now a question of theoretically, and in medicine, you're trying to treat the patient in the best way to make him or her the most comfortable with his or her treatment. But there's also this kind of social consideration that we need to take place. And so I think there's, and I think you've heard us a few points during this talk, there's actually a few points where the ethical parts of AI are not completely worked out yet. But right now, I'm just trying to argue that the technologies are going to take us there. So one last thing to think about is where are we going to see this first? So just like when I was talking about the robotics part, obviously not all of these applications are as equally easy to address, and some of them are higher risk and some of them are higher complexity. So the places where we're going to see this happening first is probably where there's low risk and lower complexity. For example, either in GP consults, in triage situations. So when people come to the emergency department and they need to be separated according to the severity of their symptoms and what's likely wrong with them. Things that
I showed you.
More assisting initially, radiology, the radiology assistant. So this is, again, what we're already seeing, these algorithms that are not trying to replace the radiologist, but rather to just support her in decision-making. As we move into surgery, it's going to be initially these things that, again, have fewer degrees of freedom and lower risk. Or alternatively, where there's no other choice. And that brings us to the second part of this slide. There are certain situations where the lack of physicians, and this is coming out very small on the screen, my apologies, but that either because of geography or because of the field, there's actually not really much choice. So if we look at this graph, the blue bar is so first of all, we're looking at number of doctors per 1,000 inhabitants. This is in 2017. And what you can see here, what's circled in red is Germany. This is this blue bar. You can see that the United States is already much lower and China is down here. So for example, the Chinese don't have really the luxury of trying to offer healthcare in the same way that we do in the West, which is with just an army of physicians and nurses. They need to do it another way. And so they are kind of forced to think about solutions like the ones that we've been talking about. Also, data protection is a little bit less sensitive in some of these countries than they are, for example, in Germany. So this is the type of thing that's going to cause some geographies to adopt these technologies sooner than others. But there's, of course, also the issue of even within a geography, there are certain types of physicians that are in short supply. So, for example, 5 years ago, there was there were a few large studies that showed that treating stroke with stent retrievers is far superior to plasminogen activator. So what we saw there is that there was a sudden shift to trying to perform as many of these stent retriever procedures as possible. We didn't have enough doctors. We still don't have enough doctors. So that would be, again, another catheterization procedure that would lend itself very well to the development of these types of solutions. So that's, I think, yeah, that's it. Let me switch you back so I can see if there are any questions that I can. I see Tomasz is asking, are you using algorithms now during the pandemic? Sounds like the perfect solution for initial conversation with a doctor. Yes, this is already happening. There are, I mean, I'm not, but there are a few companies that are doing this. I know Giant, it's spelled GYANT if you want to look it up, is doing it. And there's also, I think if I remember correctly, I saw Babylon also trying to address this. But you're right, this type of situation is a perfect one for the use of these technologies. Anybody have any other questions? If not, then I guess I will just wish everybody a safe time through these Corona crisis period. And thank you very much for having me. Bye-bye.